So what we're going to talk about in this segment is something called an operative delivery. And what that means is if you're unable to push your baby out and we need to help you deliver your baby, that is typically what we call an operative delivery. There are various types of operative deliveries, different types of interventions, and each intervention has a specific indication. What we're going to talk about first is helping you in the pushing stage of labor. So you've got to full dilatation and you start to push. And a few things may go wrong in the pushing stage, one of which is as you push, we may notice the baby's heart rate drop. And why does it drop? Because the cord may be around the baby's neck, or for some reason the baby is not tolerating the force of pushing. And so we may need to help you in the pushing stage of labor. So this is the stage where your cervix is fully dilated, the head is in the pelvis, and we need to help you to get the baby out. One, because the baby is not tolerating the process of pushing, or you've been pushing for 2 hours, 3 hours, maybe even 4 hours, and you're starting to get very tired and you don't have the energy to deliver the baby. So the two most common reasons for intervening in the pushing stage is one is the baby is stressed or the mom is exhausted from the pushing. So what can we do in the pushing stage to help you? If the baby is low down, if we can see the baby's head right at the opening, that every time you push, we can see the birth canal, the opening to the vagina, open up and we can see the baby's head right there. If the baby is really low and we just need to help the baby out through that last few centimeters, we can help you with something called the vacuum. And this is not a model, this is the real vacuum. It's called a Kiwi vacuum. It looks like something you buy from Toys R Us in aisle 3. It looks like a toy, but it is a real medical device. It is a very specific use. It's to help the baby deliver when the baby is very low in the birth canal. And what happens is we put this little disc on the baby's scalp, like that, goes on like that, and we pump it up, and it creates a gentle suction. And when you push, we help guide the baby around the bone. Remember we talked about getting the baby around the bone, so you still have to work. We don't pull the baby out, you still have to help us, but when you push, we will add the force of the vacuum to bring the baby around the corner. So it goes on easy, we apply gentle force, and the baby comes around the corner and delivers. And once the baby is delivered, we take it off. The vacuum will leave a little red mark on your baby's scalp, and that'll go away in 24 hours. Your baby will have a little bit of swelling on its head called caput, and this goes on top of that, so it looks like a double scoop of ice cream, and that goes away in a couple of days. So the vacuum is safe. It still has to be used in expert hands, and when we use it, we know what we are doing. There are specific indications to use it for, but if you need it, it is safe, it is reliable, and does a good job. Occasionally, when we put the vacuum on, as you push and we pull, sometimes the vacuum comes off and makes a pop, and the vacuum sort of flies in the air, and everyone thinks, oh, we've pulled the baby's head off. If you hear a pop, it is not your baby's head popping off, it's just the vacuum. We put it back in, put it back on the baby's scalp, and try again. So the vacuum, it is good, but its use is quite limited because the baby has to be very low down for us to use it safely. So what else can we offer you in the pushing stage to help your baby be delivered? This is called the forceps. This is not a model of the forceps. These are forceps, metal forceps. They look like they date back to something out of the Middle Ages, and they actually are. Forceps. I have 3 children. The smartest one, forceps delivery. The next smartest, vacuum. The one who's not the smartest was a normal delivery. So my smartest kid, he was delivered with forceps. Forceps have got a bad name over time, and rightfully so, because forceps can do a lot of damage, not only to moms, but to babies as well. So there are a few rules that we use before we offer you the delivery with forceps. Now, as I said, the vacuum, the baby's head has to be very low in the birth canal, almost right there. If the baby is low in the birth canal, but not low enough for a vacuum, those babies can be safely delivered with the aid of forceps. These are called low forceps. The baby is low in the birth canal. That is the most important thing to remember. The baby is low, we can see the head, we can see the hair. Forceps, low forceps are very useful, they are safe, and the only option to the forceps is a Cesarean section. And to do a Cesarean section when the baby's head is so low is actually a very difficult and complicated procedure with a lot of injury to both mom and baby. So when the baby's head is low in the birth canal, a straightforward forceps is a good option. Now, before we do anything to you, whether it be a vacuum, forceps, or C-section, myself or one of my colleagues will explain to you what we need to do, why we need to do it, what options you have, and the risks and complications associated with each. We can use the vacuum, here is why, here are the complications, and what else can we offer you. Here are the forceps, this is why we're going to offer you the forceps, these are the risks and complications, and these are the options. And the other option would be, if you decline the forceps, the only option is to do a Cesarean section. Low forceps. For us to do low forceps, the baby has to be well into the birth canal. You have to have good freezing on board. So if you do not have an epidural, we will give you an epidural. If you have an epidural, we will top it up so you do not feel it. When we do the forceps have to go around the baby's head very easily. The forceps actually protect the baby's head. And when we use the forceps, we are not here to pull the baby out. This is not a forceful thing. Once again, it's a device used to bring the baby around the bone. We don't put our foot up on the bed and yank the baby out. The forceps are designed, this part is for us to push down, and the handle is for us to push up. And so the motion is to bring the baby around the corner when the baby is low in the pelvis. The one downside of using forceps is that we may need to cut an episiotomy. We typically try not to, but if we see that when we bring the head low, the space of the forceps and the head is going to cause tearing into your anus, into your rectum, then we will make a small episiotomy off to the side to try and avoid tearing into the rectum. So low forceps are fine. If the baby is lying in a funny position, if the baby's head is looking upwards, or if the baby is higher up in the birth canal, we then may offer you what is called a trial of forceps. Not a low forceps, a trial of forceps, which means we will take you from the delivery room to the operating room, and we will try to do the forceps in the hope that they work. The low forceps we do in the delivery room. A trial of forceps, we take you out of the delivery room into the operating room. And a trial of forceps, there are different types. One type is we You may need to turn the baby's head into a different position, or the baby is higher up in the birth canal, so we're not quite sure if we can bring the baby down. If one of my colleagues offers you a trial of forceps, you are to absolutely say no. There will be no trial of forceps. Low forceps, yes. Forceps that you do in the delivery room, yes. But if anyone says we can offer you a trial of forceps, we will take you from your delivery room into the operating room to do the forceps, you are not to accept that option. There will be no trial of forceps. You will say, I will rather have the C-section. So low forceps vacuums are fine. A trial of forceps, a forceps rotation, a mid-forceps delivery is absolutely, absolutely forbidden. You will rather accept the C-section. So let's talk about C-section. There are two types of C-section. One is called an elective section, where women chooses to be delivered by C-section on a certain day, on a certain time before labor. And then there is the emergency C-section, which can be done at any time during the laboring process. They are the same procedure, but the anesthetic is different. If you have an elective C-section, you're not in labor, we do what is called a spinal anesthetic. We take a little needle, and it's the same needles you go when you get to the dentist, and instead of putting it in your gum, we put it into the back, give you a little bit of freezing, take it out, so nothing stays in your back. With the spinal anesthetic, it works very well, but it lasts only 2 hours long. It causes less shaking, less nausea, and less less nausea and throwing up, but it only lasts for 2 hours. If you are in labor and you need an emergency cesarean section, if you do not have an epidural, we will give you a spinal anesthetic. If you have an epidural in place, we will give you a big epidural top-up. And the problem with the epidural top-up is that it will make you shake a lot and even throw up a little bit. So the big epidural top-up, you will shake. And that's the difference between the two. Other than that, the C-section procedure is the same. Why would you need a C-section? One, you can choose to have it, and that's fine. In labor, why would you need it? The most common reasons are, one is your baby's not tolerating the stress of labor, that we've seen the heart rate dropping, the baby may be stressed. And the second most common cause is that your labor is not progressing. You have an obstructed labor, that you've been there for 12, 20, even 30 hours, and your cervix is not dilating, and the baby is not coming down, and we've given you an epidural, and we've given you oxytocin, you have lots of contractions, and we just can't seem to get your cervix dilated and your baby delivered. So those are the most common causes for needing a C-section. Either the baby is stressed, or the labor is not progressing, or you may want it, and that is fine. What is the C-section rate at BC Women's Hospital right now? For women in labor, for women who come in labor, it is between 20 and 25%. That's the emergency C-sections. How do we do a C-section? We try and keep the process as natural as possible. So you come to the operating room. If you don't have an anesthetic, we give you a spinal anesthetic. If you have an epidural, we top it up. Remember, I said you'll be shaking a little bit. If you don't have a catheter in your bladder, we will put a catheter in. You will not feel that. We will then prep your tummy, and then we'll put the little drapes over to keep things nice and sterile. Once you are prepped and ready, we'll bring your partner in, and they will be sitting right next to you as if you were having a vaginal delivery. We will then test you. Before we start cutting, we will make sure you're nice and frozen. And once you're nice and frozen, this is what is going to happen. We make a small incision low down in the bikini line, about 10 centimeters. And the only thing we cut is your skin. We never, ever, ever cut your muscles, it is just the skin that we cut. So we cut the skin, we separate the muscles with our fingers, we make a little hole in the uterus with our fingers, and then the only thing you will feel is us pushing on your tummy, and we will warn you and say, okay, you're going to have the baby now, you will feel us pushing, and you will feel the pressure, push, 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 and then the baby comes out, and just as with a vaginal delivery, we hold the baby and we wait. Instead of 2 minutes to cut the cord, we wait about 30 seconds to a minute. We cut the baby's cord. We have to cut it. Dads, unfortunately, you can't cut the cord because baby's in a sterile field. But as soon as we've cut the cord, the baby comes directly over to you, just as with a vaginal delivery. We want the baby skin to skin with mom or dad as soon as possible for as long as possible. So the first part, we go through the skin, we separate the muscles, we do not cut the muscles, we make a hole in the uterus, push the baby out, we delay the cord clamping, and then sooner after that, the baby comes to mommy or daddy straight away. Mom, if you feel that you can't hold the baby because you're shaking or you're not feeling well, baby goes skin to skin with dad. Once the baby's out, we deliver the placenta and we sew all the layers up. There are 7 layers, and we sew them all together, and we put a dissolving stitch under the skin, so there is nothing that needs to be done after the C-section. The C-section takes about 30 to 45 minutes in total, and once we've finished, all 3 of you will go from the operating room to the recovery room, and that's just like a vaginal delivery, where we'll start the breastfeeding as soon as possible. The recovery from a C-section is okay. It can be a little bit more painful than an uncomplicated vaginal delivery, but not necessarily so. We will give you lots of pain medication as with the vaginal delivery, and everything we give you is safe for baby. We'll give you Tylenol and Advil, and when the pain is more intense, we'll give you something called hydromorphone, which is a stronger pain medication which is safe for breastfeeding. With a C-section, you always must remember you cannot damage it in any way. So when you sit up, when you cough, when you sneeze, when you laugh, it will feel like it's going to break open. You can never break open a C-section. It is impossible. It is just not going to happen. It will feel like it, but you cannot do it. So when you sit up, when you cough, when you sneeze, you'll just put some pressure, hold it, and cough, and hold it, and support it. It will be sore, but you will not be able to break it open. Also, there is no wound care. You don't need to keep the wound especially clean. After the C-section, we put on a big dressing, which we'll take off in 24 hours, and then we leave a little steri-strip, which is a little strip, a little Band-Aid, over the incision, which you will take off, or I will take off, a week after the delivery. You do not need to care for the wound. You can shower, you can get it wet, you can use soap, you can wear pants or dresses over it. There is nothing that you need to do for the C-section wound, and the dissolving stitch dissolves under the skin. We don't need to take any of the stitches out. So the C-section, you can't break it open, you can't get it infected, and you can do pretty much everything you want to. With a C-section, we typically keep you 3 days in the hospital. With a vaginal delivery, typically 2 days in hospital. When you go home after a C-section, there is nothing that you cannot do. You can climb stairs, you can lift, you can bend, you can pick up anything. Someone may say to you, you shouldn't lift anything heavier than your baby. That is incorrect. If you feel comfortable lifting your baby, fine. For those of you that have toddlers at home, that may be a little bit more difficult for you to pick up the toddler, but if someone picks up the toddler and they sit on you, that's fine. The toddler will often put their elbow and knee into you, causing a bit of discomfort. Don't worry, they cannot break it open. It'll be sore, but they can't do any damage. So C-sections, if you need one, are safe. The recovery is fine. In another pregnancy, if you choose, you can have an elective C-section, or you can choose to labor. if you do choose to labor, we'd prefer you wait at least a year from the delivery before getting pregnant again. So ideally we'd like 2 years from birthday to birth, or 2 years from one birthday to the other birthday before you try labor. If you get pregnant in the interim, it's not the end of the world. We'd probably recommend you have another C-section versus labor, but if you want to, you can try for a VBAC, or you can have another elective C-section. And patients ask, how many C-sections can I have? I say as many as you want to. There's no limits. You want four children by C-sections, you can do that. So I've done 5, 6 C-sections in one patient. Not many people choose to have 6 children, but if you wanted to, it is fine. So the C-section, if you need it, is not the end of the world. An extra day in hospital, a little bit more pain, but the recovery is fine, and there's no restrictions for when you go home. Okay. I also want to mention the process of labor induction. And the process of labor induction is a process where we get a woman who is not in labor into labor. And why would we do this? There are a number of reasons. One is, as I may have mentioned in the earlier videos, if the waters have broken and she's not gone into labor by herself, we need to get her labor started, so we would induce her. There are other obstetrical issues such as high blood pressure, going 10 days beyond the due date, signs of baby stress or mommy stress, in which we may need to get the labor going before it started naturally. That is the process called induction. There are 2 ways of inducing labor, and it all depends on why we are inducing and how ripe and how ready the cervix is for labor. Typically, if a woman's water has broken and she's not gone into labor by herself, the process we use is the IV oxytocin. It's the IV labor hormone. And as I said before, we start an IV, we hook you up to the fetal monitor, and we give you small amounts of oxytocin until your body goes into labor. The disadvantage with the oxytocin is that you are attached to an IV and a monitor, but you're still able to walk around, you're still able to be mobile, and unfortunately you're stuck in the hospital. The next process is a process where we do an induction of labor as an outpatient, and the medication we use is something called prostaglandin. It is a hormone which is not the labor hormone, it's actually a hormone which helps ripen up the cervix. And there are 2 forms. One is a gel, which we push into the vagina, and the second, the more commonly used type, is a little tablet attached to a piece of string. Now, if you do need an induction of labor as an outpatient, let's say your blood pressure is up, or you've gone 10 or more days over the due date, something that we need to get your labor started, but it doesn't need to be done in hospital. This is what is going to happen. We will make an appointment for you. You will show up at the hospital. We will check your cervix. The nurse will check your cervix. And if your cervix needs ripening, we'll either push some gel or we'll put the little tablet into the birth canal. We monitor you for 1 hour, and then we send you home. And when you go home, you can do everything. You can eat, you can drink, you can go shopping, you can lie down, you can shower, you can do everything. And we wait for the prostaglandins to work. The little tablet does take a little longer to work, and often we give you 24 hours. So we put the tablet in, and we book another appointment to see you in 24 hours. If you haven't gone into labor in 24 hours, we will see you back at the hospital at a predetermined time. We will take the little tablet out and we'll put a new tablet in. So that's called the cervidil prostaglandin tablet. It's safe, it works well, it's an outpatient, it's very well tolerated. The gel, we don't wait 24 hours, we see you every 6 hours. We don't use the gel a lot because it does mean a lot of backwards and forwards, where the same thing can be done with the tablet. So the gel we use in very specific situations. We commonly use the tablet for induction as an outpatient, and if we need to keep you in hospital, then we will use the oxytocin. Now, before we start inducing you, we'll check your cervix. If your cervix has already started to open by itself, then we probably will not use the prostaglandin gel or the tablet. We will break your waters, start the IV oxytocin, and get you into labor that way, because that way is slightly quicker and more efficient. The outpatient is nice because you're not in the hospital, but definitely can take a little longer. So if we need to induce you, either it's the oxytocin or the prostaglandin tablet. The prostaglandins we do as an outpatient, the intravenous oxytocin in the hospital.